Now, next, I would like to call upon Dr. Samir Chapagain for presenting on difficult PVDs. Please welcome Dr. Samir.
Good afternoon, everyone. I'm Dr. Samir Chapagain, currently Vitreo-Retina Fellow in BPKLCS and Mechi Hospital. So, surgical PVD is a surgical step of separating vitreous, posterior cortical vitreous from retina. So, mostly we are using vitreous cutter in aspiration mode, and we have found particularly difficult to induce PVD in younger patients, diabetics, retinal detachments. So, for managing difficult PVDs, things we are following is repeated staining of vitreous with triamcinolone, and instruments apart from cutter we are using backwards cannula, forceps, or scraping with diamond dusters, and sometimes we also have to stain ILM with brilliant blue or ICZ and ILM peeling. So I'm sharing two videos actually. The first video will demonstrate use of flute needle. This was a case of 45 years old male with traumatic lens dislocation. So we planned for PVV and lens removal. So the problems that we faced were adherent vitreous and sheet of posterior vitreous that is not being grasped with vitrectomy cutter, probably due to very thin remaining posterior cortical vitreous. So we used backflush needle, and which was used to tease the posterior vitreous multiple times. Let's see whether or no. So I hope it's clear. So using the backflush needle to tease from periphery to the from center towards the periphery. So we had to struggle a bit. So staining, and after that slowly we had to tease it a lot of multiple times, being careful not to avoid any traction or any touch on the macula. So we had to go really near, and at the edge of the detached area in the periphery. So we are doing this. So finally we had some success in mobilizing the posterior attachments, and we can see we have successfully lifted off the attachment, the posterior cortical vitreous, and after that, after removing it, we went in with cutter and started removing the vitreous. So in next video, this is using forceps in a diabetic patient with TRD. So this was a diabetic patient with staining it with a tracker for better visualization of the vitreous. So we started the vitrectomy with a vitrectomy cutter, and because of the attachment around the disc area, it was getting difficult to lift it off with just the use of cutter in aspiration mode. So I've seen removing the peripheral vitreous, and we started because of that center we started using forceps to mobilize the membrane and as well as the posterior vitreous from the disc area. We can see some bleeding from the disc area too. So it's not ideal, but usually happens in adherent membranes. We're attempting to remove adherent membranes, and slowly we could lift it off. Okay, that should be it. So we can also see some regulations come from the water seeping in, and so right there the vitreous gets separated from the disc area. So after we were successful in removing the attachments, we went in with vitrectomy cutter and separated the rest of the vitreous, and even for removing the attachments in other areas, we also had to use vitrectomy forceps. We have to use forceps in this case also. So I don't have any poster pictures of these cases actually. So PVDs during early fellowship periods can be sources of much anxiety for particularly young surgeons. So what we are learning is we are trying to induce PVDs with as much less trauma to the retina without inducing much breaks. So there might be some tricks. So as a beginner, so these were the tricks that we are using here in Mechi. I hope it was helpful. Thank you.